All right, so good afternoon, everyone. Welcome to our Studium Generale webinar series. It's a pleasure to see many of you joining us today. So today marked the 23rd session or the 23rd episode of Studium Generale. For those of you who has been joining us since episode 1, welcome back. And for those of you who recently joined us and still unsure about what is Studium Generale about, let me give a brief introduction. So, Studium Generale is a webinar hosted by Division of MSK Radiology, Faculty of Medicine, University of Indonesia. It is a monthly academic forum, routinely held every month during new moon. And since this session held in the last week of December, so will be our final webinar before the Christmas and New Year's holiday. So we hope today's webinar can be a relaxed yet meaningful way to close the year together. As you may know, today's session is particularly special and slightly different than our usual format because for the first time, the Studium Generale is conducted entirely in English. Why in English? Because today we are honored to welcome our first international speaker. Let me introduce our guest speaker today, Dr. Stefanie Yip. Dr. Stefanie is an associate consultant at Department of Imaging and Interventional Radiology, Prince of Wales Hospital, Hong Kong. And she's also a clinical assistant professor at the Chinese University of Hong Kong. She subspecializes in MSK imaging as well as breast, neurology, vascular, and interventional radiology. She's currently serves as the chairperson of AMS or Asian Musculoskeletal Society Youth Committee, in which I'm also a member. So today, Dr. Stefanie will be sharing her expertise on ultrasound and MRI of the brachial plexus and common pathologies. Hello, Dr. Stefanie. You're
Hello,
still muted,
hello,
yeah.
hello. Thanks
Hi, okay, so
for
are
the
you ready?
introduction. Yes, I will try to screen share. Uh,
Okay. For those of you who joined us and would like to ask questions to Dr. Stefanie, may ask your questions in the chat box below. You can write it, and then I will read your questions after the presentation. You may ask in Bahasa, and I will translate it to Dr. Stefanie, or you may ask directly in English.
okay. Hmm.
Do you have any problem in sharing the screen? Let me
Share.
see.
I'm currently on. I want to share a part of my screen. Uh,
Oh,
I'm presenter view. But I can't exit the presenter view. So how do I share?
usually you can
Hmm.
from if you click the share button on below the Zoom, you can see three tabs on at the top, screens, documents, and advanced. And then you can click documents. Sorry, you can click advanced and portion of screen. Do you see portions of screen?
Yes.
Ah,
Okay.
click portion of screen, and then you can adjust the screen that you want to
How do I
share.
adjust?
You can drag the corner of the green line, the
Oh,
green box.
do I click OK or share to adjust?
You can click share first.
Okay. Do you see my screen?
Yes, I can see your screen.
Okay, and then
But this is not the full screen. I see. Oh, that's too big. I think some of your slide is cut off.
okay. Um, and then let me see if this works.
Yeah. Maybe you can start slideshow first. Yeah.
Oh, and then I adjust it. Oh, thank you.
It's perfect.
Okay.
All
Okay.
right, then the floor
All
is
right.
yours. Yeah.
Yeah. Thank you very much, Aaliyah, for the kind introduction. So yes, we are both members of the Asian Musculoskeletal Society Youth Committee, and we can also talk more about that later. So today the topic is brachial plexus, which is the neural highway to the upper limbs and is perhaps the most complex neural network in the whole body. And before I start, I would like to say that I do not have any disclosures to make. And I would like to acknowledge Professor Griffith for his contribution to these slides. So, the brachial plexus is responsible for the motor and the sensory innervation to the upper limbs and the chest. And any injury to the brachial plexus is often very crippling, as you can imagine. And so the brachial plexus, first of all, we have to understand the anatomy in order to, before we can master how to image it. The brachial plexus is formed from the C5 to T1 ventral rami, which combine to form classically three trunks, as you can see in this diagram, 6 divisions, 3 cords, and 5 terminal branches. And the terminal branches are the ulnar, the median, the musculoskeletal, the musculocutaneous, the axillary, and the radial nerves. Many variations, however, exist in this classical anatomy, and there can be variations at up to 50% of the population. In which the C4 or even the T2 spinal nerves, or both of these nerves, can contribute to the brachial plexus. And so we cannot rely on having a definite number of trunks, divisions, or cords at any location, as we can have more than one at any location. But when we image on ultrasound, it's important to remember that the roots, the trunks, and the divisions are monofascicular and hypoechoic, while the cords and the terminal branches are polyfascicular and hyperechoic. Oops, yeah. So first of all, the key anatomical landmark is the neural foramen, which corresponds to the origin of the brachial plexus. Within the spinal canal, we have the ventral and the dorsal nerve roots, which exit the spinal cord. And the ventral nerve roots would carry the motor fibers, while the dorsal nerve roots carry the sensory fibers. And so the ventral and the dorsal root would each course into the neural foramen, and they would merge to form a spinal nerve. Just proximal to the neural foramen is the dorsal root ganglion, where we see here. And this contains the first order sensory nerve cell bodies. And this dorsal root ganglion is important as it serves as an important landmark for delineating pre versus post ganglionic injury. So we see that proximal to the dorsal nerve root ganglion are preganglionic, while distal to it are the postganglionic injuries. And distal to the neuroforamen, in the postganglionic region, the spinal nerve would then divide into the ventral and the dorsal rami. And then the dorsal rami would extend posteriorly to innervate the paraspinal muscles, while the ventral rami would go anteriorly to form the roots of the brachial plexus. Here, this is an MRI of axial image correlating what we saw just now. And this asterisk is the level of the neuroforamen. And so over here would be the approximate location of the dorsal root ganglion at the region of the asterisk here. MRI is conventionally regarded as a preferred modality for imaging the brachial plexus because of good visualization of both the preganglionic and postganglionic lesions. However, MRI is intrinsically limited by its high cost, long scan time, it's noisy, and it's less tolerable. It's prone to artifacts and may not be suitable for certain patients, like those implants or claustrophobic patients. So recently, high-resolution ultrasound has emerged as the most powerful tool to assess peripheral nerve disorders and provides an alternative means to evaluate the brachial plexus. Though ultrasound may not as easily visualize the preganglionic structures because of the overlying bone, but nonetheless, ultrasound has advantages of being low in cost. It's fast and readily available. It's portable. It's well tolerated, and there are practically no patient contraindications except if there are like open wounds. Ultrasound allows bilateral evaluation, which is very important due to the high inter-individual variability of the normal brachial plexus. It allows nerves to be traced more distally into the forearm and allows dynamic correlation with direct patient interaction, history taking, and also with neck and shoulder movement. So we can ask the patient to do dynamic procedures, that maneuvers that may be able to reproduce symptoms. Ultrasound can also examine areas outside the brachial plexus if there are relevant clinical symptoms and can guide biopsy or injections such as nerve blocks. But an intrinsic limitation of ultrasound we have to understand is that preganglionic neural injury is often very difficult to diagnose. And also a small segment of the brachial plexus beneath the clavicle, which is, we call it the costoclavicular gap, is also quite difficult to assess on ultrasound. But the brachial plexus immediately proximal and distal to this costoclavicular gap region can be consistently examined. And this usually wouldn't affect our overall interpretation because it's very rare for pathology to solely and only affect this small portion of the costoclavicular gap segment, which we will also later discuss. And so, nonetheless, ultrasound is the most efficient way of assessing brachial plexus. And now, a standard ultrasound, which involves both sides examination, would only take about 15 minutes. And a negative ultrasound exam can effectively exclude most brachial plexus pathology, as the likelihood of finding an abnormality on MRI when ultrasound is normal is very low. And this is the latest consensus in the current literature, and is also the finding that I published a couple of years ago in Clinical Radiology, which I just decided to put up here. Okay, so moving on, for ultrasound of the brachial plexus, today I will focus on the scanning on an ultrasound because often it's a technical challenge to most people. There are three key pearls for a successful ultrasound of the brachial plexus. Firstly is your transducer. A high resolution linear transducer, 12 to 15 hertz, should be used to obtain optimal image quality. We don't need any lower resolution than 12 hertz. It is sometimes helpful to use a smaller high-resolution hockey stick probe for infants or young children, or for patients with small and short necks. The second caveat is standardization of technique. A systematic scan protocol should always be followed, in which all parts of the brachial plexus would be systematically examined. And thirdly, is to always scan the normal or the asymptomatic site first. Because there is such large amount of inter-individual variability in the normal development of the brachial plexus and the normal brachial plexus pathology, while there is relatively little intrinsic side-to-side variability within each individual. And so examining the contralateral or the normal side first would act as a good internal reference as to what to expect, and also would allow us to more easily identify pathology. And so routinely for ultrasound of brachial plexus, unlike MRI, we would always examine both sides, but it still takes much shorter, about half the time for MRI. And of course, it's important we have a solid understanding of the normal anatomy. Okay, so This is a scan position for ultrasound. The patient should lie supine on the examination table with both shoulders fully exposed and such that the arms can be fully abducted. We call it a tube top type of exposure. Then the brachial plexus is best examined in the transverse plane. Longitudinal scanning is usually only helpful in avulsion or traction injury, and for most part, it's not necessary. There are three scan positions. Firstly, we start with the supraclavicula to assess the roots, the trunks, and the divisions, in which the arm is placed by the side. And then, when we reach the subcoracoid region to assess the cords, we ask the patient to abduct the arm by 90 degrees. And finally, when we want to look at the terminal branches in the axillary fossa, we ask the patient to raise the arm fully to 180 degrees. Now, moving on to our second part, systematic examination of each part of the brachial plexus. And I would show some images of both MRI and ultrasound, but focus more on ultrasound technique. So first we start with the roots in the extraforaminal area, which is where the ventral rami, having branch from the spinal nerves, emerge at their respective C5 to T1 spinal levels. On MRI, as we can see here, these cervical nerve roots are best visualized on the T1 fat-saturated sagittal sequence. On ultrasound, we can also find these cervical nerve roots by identifying them emerging between the anterior and posterior tubercles of the respective vertebra. Instead of starting from the C5 vertebra down, we find a trick is to start with the C7 nerve root, which is a good marker because of its unique configuration. Unlike the other cervical vertebrae, the C7 vertebra does not have or only has a very small anterior tubercle, while it has a dominant large posterior tubercle, as we can see here. Here we outline the posterior tubercle and this very small or even absent anterior tubercle. And this gives the C7 vertebra the classical thumbs up sign due to its large posterior tubercle and absent anterior tubercle. And also the C7 nerve root also lies adjacent to the vertebral artery. Once the C7 nerve root has been identified, we can move the probe more cranially to examine the C6 nerve root, which would emerge between the anterior and the posterior tubercles, which are of similar size, as you can see. The C6 vertebra exhibits the V sign because we can see how the anterior and posterior tubercles are of similar size and tend to fan out a little bit, like the letter V. Then, moving more cranially in the transverse plane, we can identify the C5 nerve root emerging between the anterior and the posterior tubercles of the transverse process. The anterior and posterior tubercles of C5 are also of similar size, though they are less elongated than the C6 tubercles and tend to have a narrower distance between them, so have a U shape instead of a V type of configuration. We can also move the probe more cranially to identify the C4 nerve root in the same manner. Okay, next we can go to the interscalene triangle where we would see the trunks. The interscalene triangle is located between the scalene anterior and the scalene medius muscles, as we can see here within this little triangle. With the scalene anterior located anteromedially and the scalene medius muscle located posterolaterally. The subclavian artery courses within this interscalene triangle, coursing below and posterior, typically to the trunks. And this is the MRI correlate, showing the upper, the middle, and the lower trunks as well as the subclavian artery passing within this interscalene, coursing within the interscalene triangle. The trunks are located towards the lateral aspect of the interscalene triangle, where the upper trunk is formed by the union of the C5 and the C6 nerve roots. The lower trunk represents the union of the C8 and the T1 nerve roots. The C8 and T1 nerve roots themselves are quite difficult to visualize on ultrasound, however, which is also a slight limitation. And the middle trunk is the continuation of the C7 nerve root. Here we can appreciate that the upper and the middle trunks are located superior to the subclavian artery, while the lower trunk is located posterior to the subclavian artery. This stacked appearance resembles the traffic lights. And this is ultrasound showing the interscalene triangle, which is between the scalene anterior and the scalene medius muscles. And here we see the upper, middle, and the lower trunks, which resemble the traffic lights appearance. Does anyone know what this green arrow is pointing to? A tip is that it's often not considered part of the brachial plexus. The green arrow is the phrenic nerve, which arises primarily from the C4 nerve root and can sometimes be identified adjacent and superficial to the upper trunk. This interscalene triangle is often the easiest part of the brachial plexus to examine on ultrasound, and due to the relatively easy visualization of the trunks here, the interscalene triangle is often a common site for nerve block. Okay, so we can, at the traffic lights area of the interscalene triangle, there are also two important structures that we can often identify here. Firstly, the suprascapular nerve. The suprascapular nerve arises from the upper trunk and is closely related to the upper trunk towards its origin, where the suprascapular nerve would lie on the surface of the scalene medius muscle, and also deep to the omohyoid muscle. So when examining the brachial plexus, I try to also routinely identify and take note of the size of the suprascapular nerve in the interscalene triangle. The suprascapular nerve is better identified on ultrasound than on MRI. And here we can appreciate the normal size of the suprascapular nerve, which is usually larger than the phrenic nerve, but smaller than the upper trunk. This is important because to appreciate the size of and note the size of the suprascapular nerve when we routinely examine the brachial plexus, because focal enlargement of the suprascapular nerve anywhere along its course can be the only sign of neuralgic amyotrophy. Although this diagnosis is also heavily based on a relevant clinical presentation. And this case also illustrates another important structure is the dorsal scapular artery, which courses typically between the middle, between the upper trunk and the middle and lower trunks here. And we try, and we wouldn't want to injure the artery when we perform nerve block. So this is also a structure that would be useful to identify. This case also nicely illustrates the wide variability of the brachial plexus, because we see this case has one middle trunk and more than one upper trunk, as all of these three are part of the upper trunk. But still, they do resemble a traffic light's appearance due to their stacked configuration. Now, moving to the second part will be the divisions in the supra and infraclavicular portion. Lateral to the scalene muscles, each trunk would separate into the anterior and posterior division, as we can see here, at or near the lateral border of the first rib. So on MRI, we can use the first rib as a landmark. And at the same location where the trunks give rise to divisions, the subclavian artery would become the axillary artery with the adjacent axillary vein. And each trunk gives off one anterior, one posterior division classically. And so there will be 3 anterior and 3 posterior divisions, which together would form a cluster, just superior to the axillary artery and posterior to the midclavicle. And this would give rise to a bunch of grapes appearance. Though this bunch of grapes appearance is better appreciated on ultrasound, which we will soon see. The divisions of the brachial plexus are functional, in that the anterior divisions would innervate the flexor muscles of the upper limb, while the posterior divisions would innervate the extensor muscles of the upper limb. So this is the ultrasound correlate at the same level, showing the divisions at the supraclavicular region, having this bunch of grapes appearance. The divisions continue in the infraclavicular region to the costoclavicular gap. So the divisions would then pass behind the clavicle and to the narrowed costoclavicular gap, which is the narrowest area of the brachial plexus, and is also known as the cervical axillary canal. So this costoclavicular gap is bordered by the clavicle, the subclavius muscle, as we can see in this schematic diagram, inferiorly by the first rib. And this costoclavicular gap contains the vessels, the axillary vessels, and lies behind and above the artery. And is also where the subclavian becomes known as the axillary artery. And here we can appreciate the divisions within this very narrow costoclavicular gap. Next, we come to the cords in the subcoracoid recess in the infraclavicular region. The cords are often the most difficult component to see. And initially, all the cords would lie posterior to and above the axillary artery. But as they travel more laterally, there will be 3 cords that would emerge. And as their names suggest, the posterior, the medial, and the lateral cords would lie posterior, medial, and lateral to the axillary artery. And the cords and the vessels, axillary artery and axillary vein, would pass deep to the pectoralis minor muscle, as shown in this diagram, deep to pectoralis minor muscle. And this is known as the retropectoralis space, or the subcoracoid space. Here we see the pectoralis major and the pectoralis minor, and then the axillary vessels. And so this whole area is the retropectoralis space, and we can nicely appreciate the cords, the lateral, the posterior, and the medial cords, and their respective in their respective locations relative to the axillary artery. Finally, the final part of the brachial plexus are the terminal nerve branches in the axilla. So the cords would separate into 5 terminal branches. The musculocutaneous nerve, as shown here, arises from the lateral cords, so from the C5 to C7 nerve root contributions. The median nerve, and here we can see the axillary artery. The median nerve, as indicated here, would arise from the lateral and the medial cords. And that would be from the C5 to T1 nerve roots. The ulnar nerve arises from the medial cord, which is from the C7 to T1 nerve roots. And the radial nerve arises from the posterior cord, from the C5 to the T1 nerve roots. And finally, the axillary nerve would arise from the posterior cord from the C5 to C6 nerve roots. Here we can see that the median ulnar and radial nerves lie within the fascia of the axillary neurovascular bundle and tend to have this consistent type of relationship to the axillary artery, in which if we use a clock face type of analogy looking down on the axillary artery, the median nerve would typically be at the 9 to 12 o'clock position, the ulnar nerve at the 12 to 3 o'clock position, the radial nerve at the 4 to 6 o'clock position. And so, in other words, the median nerve would typically lie anterolateral to the artery, the ulnar nerve medial and anterior to the artery, the radial nerve posterior and medial to the artery. And the musculocutaneous nerve would lie outside the fascial sheath of the axillary neurovascular bundle in the plane between the biceps and the coracobrachialis. And then the musculocutaneous nerve more distally would pierce the coracobrachialis muscle. And so this would complete the normal anatomy of the brachial plexus. Yeah. So when is brachial plexus imaging indicated? Because clinical presentation of upper limb symptoms are vast and often nonspecific. Brachial plexus imaging is often indicated when we suspect pathologies, which can include primary tumors or metastatic tumors, trauma, especially road traffic accident victims, inflammatory neuropathy, neurologic amyotrophy, which is also known as brachial neuritis, thoracic outlet syndrome, or for therapeutic indications such as for a nerve block. So let's take a look at some pathologies, and I put up some ultrasound examples first. Okay, so firstly, a primary tumor. 90% of tumors of the brachial plexus are nerve sheath tumors. Uncommon, the rest would be lipomas or desmoid tumors. And 90% of primary tumors along the brachial plexus are benign, of which 90% are schwannomas. And ultrasound is useful for diagnosis and localization of these tumors. And they appear as a discrete and well-marginated ovoid hypoechoic mass of soft tissue that is along and inseparable from the nerve fascicle. The most reliable sign of a nerve sheath tumor is it being along the nerve and inseparable from a nerve with fusiform configuration, proximal and distal tapering, just like nerve sheath tumors elsewhere. And often they show posterior enhancement and mild to moderate hyperemia. Intratumoral cystic changes are not uncommon. Nerve sheath tumor, occasionally, a post-traumatic neuroma in continuity with the nerve, a swollen nerve, can mimic a primary nerve sheath tumor. And so a relevant clinical history is very important. Post-traumatic neuromas are also typically smaller, usually less than 1 cm. Here are some further examples of nerve sheath tumor. On the left is a nerve sheath tumor arising from the divisions on the left side. We know these are divisions because we can appreciate it next to the subclavian artery. And we can see this relatively well-marginated, heterogeneously hypoechoic mass with some hyperechoic content, which is along the divisions. And this is in contrast to the normal divisions on the right side. This illustrates also the importance of scanning the contralateral side, which is the right side, normal side first. It would allow you to much more easily appreciate the abnormal presence of a mass here. This is the MRI, T2 axial at the bottom and coronal images showing this medium-sized, which was 2 cm actually, nerve sheath tumor arising from the posterior aspect of the divisions in the extrascalenus region and the supraclavicular region, and this was confirmed to be benign on surgical excision. Next, apart from benign tumors, metastatic tumors are the most common to affect the brachial plexus, as the primary malignancy of the brachial plexus is exceedingly rare. And so malignancy of the brachial plexus is usually a feature of advanced disease or from nearby metastasis, most commonly from the breast and from the lungs. Metastatic involvement of the brachial plexus tends to be more painful and can be quite rapid in onset. And the patient would typically also have other sites of metastasis, commonly the pleura, the bone, or metastatic lymph nodes. A difficulty with metastasis may be scurrous metastasis, which can appear similar to fibrosis, and this may require biopsy. And here we see the clavicle and this adjacent lymphomatous mass. This is a case of a 68-year-old man with known diffuse large B-cell lymphoma and arm pain for 2 months. And transverse ultrasound of the supraclavicular region shows the normal divisions on the right side here, which lie lateral to the subclavian artery. And we can also appreciate from this image the suprascapular nerve, which lies deep to the omohyoid muscle here, the omohyoid muscle, and the suprascapular nerve lying deep to it. And it is normal, the suprascapular nerve. However, on the left side here, we can appreciate that there is this focal heterogeneous mass, which is encasing and causing severe and encasing the divisions of the brachial plexus on this left side. And this was proven on biopsy to be a lymphoma infiltration of the divisions, and also on this left side, the suprascapular nerve. And this is the MRI correlation showing the lymphomatous deposit encasing divisions of the brachial plexus adjacent to the subclavian artery and the scalene medius muscle. This is not the case of metastasis of the brachial plexus, showing this large heterogeneous hypervascular mass. It's heterogeneous and does not appear as discrete as what we the benign nerve sheath tumors we saw. And it also typically exhibits vascularity. And this is encasing the cords. And subsequent surgery revealed a diffuse large B-cell lymphoma, completely encasing the divisions and also the cords of the brachial plexus. And so for metastatic infiltration, it is more likely if it's hyperemic, if it's discrete, if we also identify enlarged metastatic lymph nodes indicating other sites of involvement, and there will not be the tethering type of appearance. So it'll be more discrete than fibrosis without a tethered type of appearance. And we would often biopsy to confirm it. Another common pathology of the brachial plexus is radiation plexopathy. And there is typically a 1 to 2 years latency from RT to plexopathy. Radiation plexopathy often shows a enlargement of the nerve fascicles, which tend to adhere together with increased echogenicity of the surrounding fatty tissues due to atrophy and fibrosis, and often involves more than one component of the brachial plexus. And the overlying subcutaneous tissues often become thinned, meaning they're suggesting atrophy, or they can be thickened and rigid, suggestive of fibrosis. Here we have a case of a woman with pain, unilateral left upper limb pain after left-sided radiotherapy for breast malignancy. And transverse ultrasound on the normal side shows the bunch of grapes appearance at the of the divisions. Whereas on the right-hand side, on the affected side, we can see these thickened, irregular divisions, which appear tethered to each other. And the surrounding fat is mildly more hyperechoic and has this dirty type of appearance, indicating that there is also there is thinning of the overlying subcutaneous tissues and also thinning of the overlying muscles with atrophy of the omohyoid and the trapezius muscles compared to normal appearance on the left side. And also when you scan, you can also feel that the tissues appear stiffer and the tissue planes appear distorted and have this very dirty type of appearance. And so this is a radiation plexopathy affecting the divisions of the brachial plexus. In the trunk area, radiation plexopathy can just appear as increased size of the trunks and obliteration of the perineural fat, which may show increased echogenicity as seen on this side. And we see, unlike the previous case, where there is atrophy of subcutaneous tissues here, there is thickening and increased hypoechoic signal within the overlying subcutaneous tissues, indicating that it's more rigid and there is fibrosis. This is MRI correlate showing the normal side, the divisions, and also on the right side here, we see the affected clumped, dirty type appearance of the affected divisions. So radiation plexopathy is more likely if there's enlargement of the nerve roots, poor delineation, if the surrounding fat appears dirty or obliterated, if there's clumping, hyperemia, and also look at the surrounding tissues if they're very stiff or atrophic. Now, trauma. It's important to differentiate pre versus post-ganglionic injury because post-ganglionic injury can be repaired. Here, these images show the pseudomeningocele, suggestive of a preganglionic type of injury with avulsion of the nerve root. As we see, the empty nerve root here. This is a case of a 28-year-old motorcycle accident victim. T2 weighted coronal images and neurography on the right side, showing that there is a lot of edema and thickening in the region of the divisions and the cords, indicative of injury to this region. But then, further specificity as to the degree or the site of nerve injury could not be discerned in MRI. And this was reported as improbable injury to the brachial plexus between the scalene muscles and the axilla. However, on ultrasound, here we can see that this is the affected side musculocutaneous nerve. It's swollen to 5 times the normal size. Here I highlighted the normal size on the right side, whereas on the left side, it's the musculocutaneous nerve about 5 times that size, with a cross-sectional area that was measured to be 14 millimeters squared on the affected side compared to just 2.5 millimeters squared on this normal side. And not shown here, but then there was also swelling of the cords and on the affected side. And on longitudinal scanning, we confirmed that this is the normal side. On the right side, on the affected side, the musculocutaneous nerve was significantly swollen, but there was no neural discontinuity. Follow-up 2 months later shows also a swelling of the posterior cord here, and also a neuroma and continuity with the posterior cord. And subsequent surgery confirmed complete loss of musculocutaneous nerve and also lateral and posterior cord injury. So this case illustrates that in certain cases of trauma, ultrasound can actually be better than MRI in providing more precise localization of the site of injury, able to localize the specific peripheral nerve, which is not possible in MRI. And so it enables the specificity and can confirm that there is no definite neural transection. again, reminding us of the neuroman continuity and this traction injury to the musculocutaneous nerve. Next, we go to inflammatory plexopathy, which presents as a diffuse and smooth enlargement of the affected nerves with normal echo texture of the surrounding soft tissues. Here is a non-traumatic demyelinating neuropathy, which can be due to a wide variety of causes, though commonly may be CIDP and Guillain-Barré. And so this case is a gentleman with a severe smooth enlargement of the superior, middle, and inferior trunks. And the surrounding soft tissues are clean. And this was a case of chronic inflammatory demyelinating polyneuropathy. Now, finally, we go to neuralgic amyotrophy, also known as Parsonage-Turner syndrome or brachial neuritis. Here at MRI, we see this on T2 fat sat diffuse edema suggested denervation changes in the supraspinatus muscle. And on ultrasound, it would appear as enlargement of the nerve and typically affects the suprascapular nerve or the long thoracic nerve. And in this case, a case with sudden onset right wrist drop and numbness, here we see the suprascapular nerve on the normal size, and over here the much swollen suprascapular nerve. And this was the only finding, and subsequent MRI showed atrophy of the supinator and brachioradialis muscles. In this compatible clinical presentation, the diagnosis of neuralgic amyotrophy was made. Sometimes neuralgic amyotrophy is better diagnosed on MRI, often actually, because the only abnormality may be denervation changes. Here is the atrophy. Okay, now before we finish, I hope everyone is still awake. I have a couple of cases for quiz time. I'm not sure how, do you guys want to vote or not sure how, Aaliyah, do you want to vote or yeah, so this is a 50-year-old road traffic accident. And so what is the diagnosis here? Aaliyah, do you want to vote or how do you want to do this?
They can answer their question by writing in the chat box, I think. Choosing
Yeah,
which one, A, B, C, or D.
yeah. Okay. Yeah, I see some B's. Yes, you guys are correct indeed. So this is a easy one to start with. It's a nerve root preganglionic avulsion injury. So we see that the this is level of the C8 T1 neuroforamen, and the C8 nerve root is missing here within the neuroforamen. And there is this focal outpouching going towards the left C7 T1 neuroforamen, which was suspicious of a pseudomeningocele. Okay, second case, so which part of the brachial plexus is abnormal? And type your answers in the chat box. Yes, that's correct. It's the divisions, which is abnormal. Because we are in the supraclavicular region, and also we are beyond. So yes, this is the divisions area. We are beyond the interscalene triangle. And then, so what is the diagnosis for this case? I didn't put up any multiple choice questions. See if anyone can guess it. Although I do understand it's a bit difficult to appreciate on these static images, but this diagnosis is quite unique. That's why. And a tip is that it was not one of the common diagnoses I covered, because that would be too easy. So since we don't have much time, I would just go for it. And this is the abnormality, which is T2 hyperintense. However, there is it's he was T2 very dark signal, suggested hemosiderin. And it's surrounding the divisions, and also very closely related to the axillary artery and vein. This is a patient with road traffic accident. The clinical history is very important in brachial plexus pathology, and it's a sudden onset of upper limb symptoms after the accident. There was no evidence of traction injury to the nerves. However, this was found to be a arteriovenous malformation surrounding the divisions of the brachial plexus, which is found on surgery. And so that brings me to the end of my presentation. Thank you very much for listening. Thank you, Aaliyah, for inviting me. I hope you appreciate that ultrasound is just as good as MRI for imaging the brachial plexus and is much more efficient.
And an engaging presentation.
Yeah, thank you. And I just take a moment to just say that the Asian Musculoskeletal Society, since we're all interested in MSK, would welcome your membership if you're interested. I'll just quickly switch to Aaliyah and then switch back to show you how to sign up. And we are both, me and Aaliyah are both members of the youth committee. And I also thank the organization for inviting me because I think it's a very good a project that or project an initiative that you have to have this regular type of sharing, which we don't have in Hong Kong. So yes, thank you. I'll just stop share for now, and then would like to share later, like in a couple minutes. Thank you. I'm not too sure how to. Oh, stop share. Got it.
Thank you so much. Yeah, you have stopped the sharing. Okay, thank you so much, Dr. Stephanie, for your presentation. For all the participants, let me remind you again, for those of you who wishes to ask questions to Dr. Stephanie, please write your questions in the chat box below, and I will read it to Dr. Stephanie. While we're waiting for the questions, maybe I would like to ask some questions, but this is to your institution. Is it routinely, is the clinician routinely asked for ultrasound of brachial plexus, or they just ask for the MRI? Because to be honest, I think in Indonesia, especially in my institution, the request for ultrasound of brachial plexus is still not very many. They usually just ask for an MRI instead. So what do you think about that?
Thank you,
Yeah, do
Aaliyah.
you
It's
think,
a very
yeah, do you think,
practical question. Yes, indeed. Initially they never requested ultrasound. However, we did a study, which is a study I published. So, in which every single patient with MRI, we did ultrasound on them first. And then we did a complementary ultrasound on those cases first, and then we did MRI. And then from then on, afterward, clinicians started issuing more ultrasound requests because we tend to entertain the ultrasound request sooner, so we can have urgent much sooner. Whereas for urgent MRI, the queue is long because we have a dedicated team to ultrasound MSK in certain sessions, whereas you will have to queue with other like for a spine, and typically spine injury or even traumatic hip fracture would be prioritized over brachial plexus injury. And so this is how we got more and more referrals.
yeah, it's the same problem with us, where the MRI usually the queue is very long, and yeah, the clinician need to know the answer soon, yeah, and then they will request the ultrasound. I see there are some questions here in the chat box. I would like to ask, are there anatomical variants that may mimic pathology on brachial plexus ultrasound?
Oh, pardon, do you mind to repeat the question again, please?
Oh, they're asking, are there any anatomical variants that can mimic pathology on brachial plexus ultrasound?
Mimic pathology, so it's not actually abnormal.
It's an anatomical variant, maybe. Maybe when you see something on the ultrasound, it's actually an anatomical variant
Ah,
of
right.
of the
Oh, right.
nerve, or
Oh,
maybe the
yeah.
surrounding structures. Yeah.
Yeah. Yes, indeed. Because just the nerve enlargement by itself, or part of the brachial plexus being enlarged by itself, may be the only feature of a inflammatory plexopathy or neuralgic amyotrophy. And if we abnormally, as I say that the nerve is enlarged when it's actually normal, then we may miss or overdiagnose it as abnormality, which brings us to the importance of scanning the contralateral side first. But even so, it is possible to make this mistake because for certain cases like CIDP, where the nerves are enlarged everywhere, certain individual variations may be such that you think that both sides nerves are big, but actually they are normal for this patient. And so scanning more patients to allow you to appreciate what the normal size of brachial plexus is would be in part able to overcome this. And having said that, most scanning the contralateral side first would be very important. So to avoid this kind of error.
Are there any normal size according to the literature, normal cross-sectional area according to each part? Are there any literature about that?
Yes, actually, but there is still lots of variation. There are some yes, you're right, there is literature. Um, but there is still a lot of variation.
Yeah, so the important thing is still to compare it with the
Yes, in
contralateral
fact,
or the north side to really
yeah, so
to
I
really
have
know whether
some
there are any
reference.
pathologies.
Yeah, yes, you're right. Some references like guideline, for instance, for the trunks, they're usually less than 8 millimeters squared. Um, and also for the distal nerves, like the terminal nerves, um, they're usually also less than 10 millimeters squared. So anything that's bigger than 1 cm or about 1 cm in size would be suspicious.
Yeah, so we can use 1 cm as the cutoff for normal and pathology. All right, so another question. Can you please once again explain how much between pre and post-ganglionic brachial plexus injury on ultrasound?
Oh, pardon. It kind of uh
Can
I
you
didn't
hear my
catch.
voice?
Yeah, I think your voice broke a little bit.
Oh, okay. So the question is, can you explain how to distinguish between pre and post-ganglionic brachial plexus injury on ultrasound?
Ah, right. So we use the dorsal root ganglion and basically we go up to the nerve roots. So we identified the nerve roots um, and basically ultrasound cannot see preganglion injury. So because where we see the nerve roots coming out, it's already beyond the spinal nerves. And so ultrasound actually cannot really diagnose preganglionic injury, which is an intrinsic limitation. So if we suspect avulsion or pseudomeningocele, still we need to do MRI.
So you don't see any abnormalities on the ultrasound, maybe we can perform the MRI for the patient to
Yes,
actually find the
exactly.
pathology.
Yes, exactly. That's why we use ultrasound as a good screening tool to determine which cases would require further assessment by MRI.
All right. I think that's it, the question. Thank you so much for the great questions. And once again, thank you, Dr. Stefanie, for sharing your knowledge and experience with us this afternoon. Before I end today's session, maybe our head of division, Dr. Marcel, would like to say a few words. Is he still in the video? Oh, yeah. Hi, Dr. Marcel.
Yes, hi. Again, on behalf of everyone here, I would like to thank you, Stephanie, for your contribution to our Indonesian colleagues this evening. It is a pleasure to see such a nice presentation from you. And one more thing, could you please also send our regards to Professor Griffith? he's been helping us too for many, many years in seminars and workshop, and we are eager to hear more from him also.
Oh, so does Professor Griffith also give you this presentation as well? So
Oh,
does he also contribute to here? So I guess Professor Griffith also contributes to this type of a sharing with your society.
yes.
Oh, okay.
Yes, send our regards to him, please. We
Yes.
have not seen him much lately. Maybe he's
Oh,
very busy.
yes, yes.
Okay, thank you again. And hopefully we can meet again in the future in the musculoskeletal events. Thank you.
Yes. Thank you. I just want to also share this committee that both me and Professor Griffith, and also probably many of you are already part of this committee. Just want to quickly share, because I just found the poster in case anyone wants to join. Okay. 1 second. It's sorry. 1 second. Yeah, so this is AMS, and feel free to join if you're interested. You just scan the QR code. And I'll also thank you for inviting me.
Yeah, thank you so much for joining us this afternoon. So the AMS is going to be held next year.
Yes, in Ahmedabad. Never been there.
Okay, so we would also like to thank everyone who has joined us this afternoon. And maybe I will close today's session, as this is our final Studium Generale webinar before the Christmas and New Year's holiday. So I hope this session can be a meaningful way to close this year. Happy holiday and good afternoon, everyone. Bye, Stephanie. Thank you so much.
Thank you. Thank you. Good night.
Hey, happy holiday. Thank you.
Thank you.